All your favorite products under one roof in Bahrain from our 14 branches at 27-year-old Megamart and Macromart. Bakery, fresh meat and fish, fruits and vegetables, sweets and snacks, ready-to-eat foods, dairy products, grocery or consumer goods. To have a wonderful shopping experience, please visit your nearest Megamart Macromart branch. Megamart and Macromart, full of goodness.
The groundwork for all happiness is good health. Good evening. Welcome to a brand new episode of BMC Global Live Al Hilal Health World, Nothing But Lifestyle. This talk show is exclusively with expert doctors of Al Hilal hospitals and medical centers. Radiology is a medical technology that uses medical imaging to diagnose diseases and guide their treatment. Today we are delighted to have with us Dr. Jayashree Rajkumar from Al Hilal Hospital, Muharraq. She is a consultant radiologist with an experience of more than 15 years. And we are going to discuss about general radiology and breast imaging. So doctor, welcome to the show and thank you for joining us today.
Oh, it's lovely to join you.
It's our pleasure to have you here today.
It's my pleasure as well to join you and discuss about general radiology and, as you said, mammography. So I hope it's going to be a great afternoon.
Thank you, doctor.
And thank you for having me here.
It's a pleasure. So doctor, you are a consultant radiologist.
Yes.
So what does your specialty deal with?
That's an interesting question actually. A lot of people think radiology or radiologists are basically technical people, but
Yes,
we are actually medical doctors. And this is a very evolved specialty of medicine where we deal with medical imaging. So we have different modalities, like we deal with X-rays, ultrasound, CT, MRI and mammograms. So basically we deal with imaging and we give a diagnosis and from there the treatment takes over. So we are clinical people. We deal with imaging and giving you a diagnosis of what exactly is happening. So that's our specialty. And it's evolved into another division where you have intervention radiology as well, where we use these medical equipments or the technologies to do image-guided procedures. So in fact, we treat in certain disease entities, especially when it involves intervention radiology. And we also use image guidance to do biopsies and image-guided procedures, which cannot be done without a guidance. So we do have a very major role to play in diagnosis and treatment of the patients.
Okay, doctor, now you mentioned about some of the modalities. So how do you decide which modality is better than the others in a particular clinical situation?
That's an interesting one. See, I did tell you that we deal with a lot of modalities like X-rays, ultrasound, CT, MRI, and all that. So we choose the modality based on a particular clinical scenario. So for example, if a patient has a disease which can be picked up in one particular modality, then that would be the ideal modality to go forward with. Suppose the patient has a trauma and he has access to X-rays. Well, X-ray will be the first modality which he will undergo to pick up his disease, his fracture. Suppose he is dealing with a problem of the joint, then you could have MRI being a better modality in evaluating that, and CT also comes in hand to show the bony pathology in a much detailed way. So basically, each modality has its own advantage and disadvantage. As an example, if we have to deal with the uterus and ovaries, for example, ultrasound will be a widely available, easily available, cheaper option to evaluate the pelvis. And if we want to take it further and we want to have a detailed imaging, well, MRI would be an ideal modality to go forward and be a decision-making tool rather. So to make it very simple and clear, every modality has its own advantage and disadvantage, and every modality has to be used in a particular way, in the accurate way, to come to an accurate diagnosis. And our clinicians are very well versed and they are very well aware of what to ask and why they ask these modalities, so to get the proper answer. Because we are basically people who give you the answers of what is happening inside the patient. So unless we use the proper modality, it's very difficult to come to a proper diagnosis. So we at Al Hilal are very well versed, and our colleagues are very intelligent to ask the right investigation for the right patient, and we've been doing it excellent work back in our department.
So today our topic of discussion is also mammogram. So please explain about in detail for us, doctor.
Mammogram is a very, very important topic, and thank you for bringing it to the discussion. Well, I have a good experience in mammography, and I've done my postgraduate thesis in mammography. So personally, this modality is something very close to my heart as well. And being a woman, well, I should have a special liking to this modality, because this is one modality where we can help our womanhood. So what is mammography? Well, that was your question. So mammography is a modality where we use X-rays to image the breast. So the other common modality is ultrasound. Well, I will tell about that as well. And we do have a very important role of MRI also in breast imaging. So now this takes me to breast imaging in total. But let me finish mammogram and explain the rest of the things to you. So I said mammogram is a modality where we use X-rays to image the breast, because we need to screen the breast to pick up disease earlier. So then that comes to a confusion, like, what do you mean by screening? So screening is a particular program, or you screen the breast to pick up a disease before it manifests. So basically it is kind of a preventive imaging. So screening, people who undergo screening are not patients. They are common people. But we are trying to pick up diseases in them, even it becomes a pathology. So even before they palpate lumps, how do you know we have a problem in the breast? We are trained to do proper self-examination. Well, that's a separate topic by itself, because we need to know how we have to examine ourselves properly to make sure that we have any abnormality in the breast. So we've been fine, we've been doing a routine self-examination, but there is a particular time when we should be doing a screening. Ideally, there are so many guidelines that have been given which are telling us to do screening, of which we commonly follow the American College of Radiology guidelines, where they tell us to start, if it's a common person and doesn't have any high risk or any family history or doesn't have any previous history of malignancy and things, well, we routinely suggest, the ACR routinely suggests mammographic screening at around 40 years. Okay. So it's not mandatory. They have an option to start their screening process at 40 years. And it is mandatory that they have annual breast screening with mammography from 45 to 55 or 54 years. And after 55 years of age, if they're going to have a very healthy lifestyle and they're going to have a good longevity, then they would still go on to have annual mammograms till they exist. So ideally, we want to catch up women in the 40 to 55 years of age and screen them and pick up a disease even before it manifests so we can treat them. So why is that we're so worried we want to catch the disease early? Because when we catch the disease even before it manifests, the treatment is better. It can be curable. So that's our main aim in doing screening, and that's why we have all this Pink October in the month of October, where there's intense screening of breast cancer happening, because that's one disease when you would pick it up in an early stage, you can treat it completely and you can cure it. And they don't have to undergo deforming surgeries or which disfigures you. You can really have very good cosmetic outcomes also when it is diagnosed earlier. So when you do screening, we basically in mammogram, we try to diagnose specific pattern of calcifications which are very, very commonly seen in hidden cancers, like we call the DCIS. I don't want to use a lot of technical terms, but our aim is to pick up calcifications and areas of architectural distortion where the normal breast parenchyma doesn't happen. So we target that area and we go and do a biopsy. And when it's a young breast and when it's a very glandular breast, with mammogram, we use ultrasound as an additional modality. So we combine both of it and we try to come to a diagnosis. And screening not only happens in mammography. For women who've been having breast cancer, BRCA mutations, where they have genetic mutations, and they have this cancers running in the family, well, we could start the screening process much earlier than the 40 years. And they do start screening not in mammograph or ultrasound, they start with MRI. They could start it even at 25 years and they do a breast imaging with MRI, and it goes on till 40, and after 40 they go to the x-rays and they do their mammographic screening. So it's a very big complex topic, but what I would like to simplify is that we do the screening for women at 40 years, and our main aim is to pick up cancers before they manifest, so we cure them. So that's the basic idea of screening, and mammogram has a very important role in doing that.
Okay, doctor. Now, another common query is mammogram a painful procedure?
If I have to be honest with you, well, I wouldn't call it painful, but it's it causes a little bit of discomfort. And that's why we ideally suggest to have our mammograms in the first 10 days of your cycle. Immediately you finish your cycle, because the hormonal changes are such that the breast is not tender, and it is not, and the diagnostic capability, or it's easy for us to, get a better diagnosis when it is done in the first 10 days. And when we do the study, we just try to flatten out the breast by giving gentle compression on the breast. So that causes the pain or discomfort. So yes, it's true, but you could minimize it by doing it in the first 10 days. And if at all we have to do a diagnostic mammography, well, that takes us to screening and diagnostic. There are two kinds of mammography. But screening, as I told you, we deal with people, not patients. They don't have any symptoms.
Normal people.
Yeah, but diagnostic is patients come. They are patients. They come with a problem. They either feel a lump, or they have pain, or some nodularity, and we want to see what's exactly happening. So for those people, we could do it in any point of time. So during that time, if there is a pain, well, we try to be gentle, and I think it's worth bearing the pain. But honestly, it's not that pain. It's a little bit of discomfort. I think any procedure might have a little discomfort, and I think that should not be the reason for not having a mammogram. That doesn't justify that. So I've been very honest with your question.
Actually, we usually hear people telling that is a painful procedure. That's why I asked you.
Yeah, even injections are painful, but what to do? We have to take it because, that's more important. That's a short-lived kind of a discomfort, and they're going to be fine with that. And we take all the precautions, all the measures to make sure that our patients are very comfortable and they go out of the mammographic suit smiling, and it's always been happening. We take care of them well.
So doctor, now you explained about many modalities. Which are the modalities that have more radiation?
Radiology is radiation. I think you're equating with that. Fine. See, I told you we deal with X-rays, ultrasound, CT, and MRI. So X-rays and CT are basically modalities that deal with radiation. And ultrasound and MRI do not have radiation. But at the radiology suite, we take all the precautions to make sure that all the procedures are done in the ideal way, and we do have a lot of guidelines in following. So it's called the LRR principle, as low as reasonably achievable. So we do use very minimal dose of radiation to get the best possible image, to give the best possible diagnosis without a confusion. And as I told you, every modality has its advantages and disadvantages. And in certain clinical situations, CT is much better than the other modalities which does not have radiation. So we do make a informed decision on that, and we do the best. So you don't have to be worried about radiation in that. It's very acceptable amount of radiation that we use in coming to a diagnosis. I think that's more important. And then about the modalities that do not have radiation, well, with the ultrasound and MRI, they do not have radiation. They're very safe. And ultrasound, in fact, is very cheap, very easily available. You can repeat it any number of times. And in fact, for fetal imaging, that's the major thing. And we deal with pediatrics. We deal with pregnant mothers. So ultrasound has a very, very important role in imaging, and it is absolutely devoid of radiation, and that's why it's being the recommended modality for these imaging. And MRI also has a very important role in pediatric and fetal imaging also. But usually we recommend MRI in the second trimester of pregnancy. We usually avoid doing MRI in the first trimester. In certain clinical situations where ultrasound is a little doubtful, then MRI comes as a very important problem-solving tool, even with fetal and pediatric imaging, especially when you have problems with the placenta, or when you have fetal anomalies. Then MRI does become a problem-solving tool.
Okay, doctor. Now, for some instances, we are advised to go in empty stomach for screening. Sometimes we have to go with bladder full. So what is your suggestion?
Actually, it's a very interesting question, actually. True. When patients come to us for ultrasound, we give specific instructions For some people, we tell them to come on empty stomach. Some people, we tell them to drink water and wait so the bladder is full. For some patients, we tell them to empty the bladder and come. And everybody's sitting outside and they're discussing. And as you said, there are difference of instructions that's been given. So, well, though it seems to be a very simple, but it's a very sensible question that you've asked. The reason that we give different instructions to different people, because we are trying to look at different pathologies in each one of them. Suppose, if I want a patient who's come with the right upper quadrant pain, so basically we're trying to look at the gallbladder, the pancreas, and all that. So when we want to image that, we want the gallbladder to be in a distended state. Gallbladder is like, it's an organ, it's a viscous organ. So when we have food, it collapses, it contracts. So we wouldn't know what's exactly happening inside. So if we want the gallbladder to open up and blow up like a balloon, we want it to fill the bile. So if the patient is on a fasting status for 5 hours or an overnight fasting, the gallbladder fills up well. So if we have a little bit of tiny calculi or some sand within it, or you have a polyp, all that comes up very beautifully. So that's why the instruction given to them is to come on an empty stomach. Suppose the patient comes for a colic. He's got a renal pain, he's got stones and all that. We want him to have a full bladder, because only if the bladder fills, again, the bladder has to fill to show us what is exactly happening inside the bladder. So only then you'll be able to see the kidneys and bladder well. So that is the instruction why we want them to come. And sometimes what happens is a patient comes with a prostatic pathology. So we want him to empty the urine and tell us how much he's retaining. So we want to see if his bladder emptying capacity is good. And for some women, we want to do a transabdominal scan. Sometimes we will do a transvaginal scan. So for a woman who wants to undergo a transvaginal scan, we want her to empty the bladder. So with a full bladder, it's going to be difficult for us to do a vaginal scan. So when she comes on an empty bladder, it's easy for us to do a vaginal scan to look at her uterus and ovaries in a very beautiful way. So though the instructions are different for different people, we are ultimately trying to make the best preparation. So we get the best images as possible, and we get the best diagnosis. So it depends on individual's clinical scenario, and it depends on what the clinician wants us to see, and it depends on what we want to see. So that's why the instructions are different, but it's not to confuse you actually. At the end, we want to give you the best possible diagnosis from our department. So that's it.
So doctor, you explained it in detail and it was very interesting.
Thank you.
So now can you explain about which are the scans you prefer for the pregnant ladies?
Pregnant ladies, fine. We don't have any difficulties in deciding what scan have to be done in pregnancy, because we have a very excellent gynec team back home, and in the department, and then they decide the scans, the duration, and what kind of scans that need to be done, and they give us perfect instructions to us and to the patients so that they have the right scan at the right time. So I'm very happy with our gynec colleagues there. And basically what are the scans that we do in pregnant women is, the first scan is the early pregnancy scan, where it's called the viability scan. So we do it around 6 to 7 weeks to make sure that the baby, what you call the embryonic pole, the baby started forming well and the heartbeat is started or picked up. So that's the first scan that a woman ever had, the pregnant mother ever undergoes. So once that is fine, and then she follows up with the gynec, the obstetric department, and then they come back to us at around 12 to 13 weeks, ideally. And that is the time where we do the NT scan, or the nuchal translucency, or the nuchal thickness assessment is made at that time. So that is a scan which is very important, where we look for the presence of fetal nasal bone, and we look for the thickness. That's called the nuchal thickness, or the nuchal translucency. And we make sure, that's one of the important tests to rule out trisomy or chromosomal disorders like the Down syndrome. Usually it's called the Down syndrome screening. So, but the nuchal thickness gives information about a lot of other things as well, but it's commonly called the Down syndrome scan. So we look for it, and our gynecologists will prescribe a blood test as well. So from there, that's the time it happens. And after the 12-week scan, if at all needed, if at all they want to do, they've skipped the blood test at 12 weeks and they want to do a quadruple test or an associated blood test, then they would have an intermittent scan between 12 weeks or 20 weeks. Otherwise, from the NT scan or the 12-week scan, we go to the next important scan, which is called the anomaly scan. That's the most important scan of the entire pregnancy, and that's a scan which takes quite a bit of time. where we spend enough time with the mother and we are trying to pick up if there are any abnormalities or anomalies happening with the baby. So that's quite a lengthy scan, and if the baby is not in the proper position, we might have to ask them to go have a chocolate or eat something or just walk around. So we make sure that the baby is in the right plane. Okay. So we try to get the maximum anatomical information about the fetus. So usually we prefer doing it around 18 to 22 weeks, but ideally when the baby is around 20 to 22 weeks, the baby is a little larger and we're able to get the best anatomical information. And then after the 20 weeks, it's optional that they have, suppose we make a comment on the 20-week scan, then they come back to us at around 25 or 26 weeks to have a review or for the assessment of the interval growth or to have a cardiac reassessment of the fetus. Well, all that happens around 25 to 26. And then the baby goes to the third trimester, which is like 30 plus week. So that's the growth scan. So somewhere around 30 to 32 weeks, we assess the growth of the baby, the fluid, the weight gain, and all that happens. And then after that, it becomes a term scan, which is close to the delivery. So like 36 plus. So where we assess again the weight, the fluid, and if needed, we would have to assess the blood supply. That's called the Doppler assessment or antenatal Doppler study of the fetus. Well, that could be done. And the position of the fetus, if the head is down, that's very important. All of us ask, like, ma'am, has the head come down? So that's a big concern because they think if the head is going down, then the normal labor is going to be very easy. So usually, so this is the routine pattern, and we could have additional scans in between with regards to the individual clinical scenario. So the routine scans is like you do a viability scan, you have an NT scan, and you have the anomaly scan, and then you have the interval growth scan, and then you have the term scan. So at least a minimum of 5 to 6 scans are happening with us.
During pregnancy.
Yeah, and interestingly, if the mother wants to have a 3D or a 4D of the baby, ideally we suggested between 25 to 30 weeks, where the baby looks more nice and you have a little bit of fat happening, and then you have a good amount of fluid also. So we need a good amount of fluid for the images to look very beautiful and presentable. So ideally around 25 to 30 weeks, we could do a 4D scan and we could take the images of the baby, and they look, like real pictures, and you could see them moving their hands and legs and all that, and the parents are extremely excited and happy when they see their real baby. And that's one interesting thing, and I think everybody should go for it. You get to see the baby's face, so beautiful. Sometimes it opens your mouth and moves the hand and all that. It's really an exciting thing, and everybody in the scan room feels happy for the parents, and they also are extremely excited. You could see it in the face of the mother, and I think these are small things that make us happy in the scan room.
Okay, doctor. Now, what is your advice for our viewers? Any message from you for our viewers?
Basically, it's very important that we have proper knowledge of what kind of tests that they're going to undergo, and we don't expect everybody to know the details of radiological imaging. But if there is any doubt, they could always contact us and talk to us and get the prescriptions and the precautions. We're always open to help them and discuss things with them, so they can always take advice from us, and we're always there to help them. And with regards to mammography, well, it's very, very important that they have the message that once they are 40, they have to start the screening process. And if there is someone who's got a positive family history, well, they could start the screening earlier. And it's very ideal that they have both mammogram and ultrasound as a complementary test. Rather than having it as a single test, I would honestly suggest them to have, when they come for a breast testing, it would be very wise if they would take a mammogram and ultrasound together, because they have they do complement each other and they give better results. So that would be my personal advice, and I think we should really take care of ourselves, and I think no one should miss a mammogram once they are 40. I think if that's the message that is delivered, then my job is done.
Thank you, doctor.
Oh, thank you so much.
I appreciate you joining us and giving us a lot of valuable information about radiology and also breast screening, imaging, everything.
Thank you so much for having me. It was great talking to you, and these are certain basic things I expect everybody to know, and I'm so happy that I could share all this information with you, and it was a great afternoon. Thank you so much for having me.
Thank you once again.
Thank you.
So viewers, make your health a priority, stay safe, stay happy always. Till we meet again, this is Jessila Mujib signing off. Good night.